Occasionally there'll be radiographers who will tell you that you can centre a little touch lower to make sure you include the bladder, or you can centre a little touch lower because the kidneys sit much lower below the diaphragm and so. But to be quite honest, for a patient who is of a normal size and body habitus, just a normal abdominal x-ray will be enough. Okay, so in all ways, the supine KUB is an abdominal x-ray. It should look, well, that's exactly the same criteria radiograph for the KUB as I have used for the abdomen. So once again, our statements such as making sure that you include about half of the pubic symphysis or to the curvature of the obturator foramen, show as much of the diaphragm as you can, but recognising that it will often be cut off, and to check your rotation by things such as pelvic symmetry and symmetry of bilateral structures, and also things like making sure that your vertebra are in the middle, your spinous processes are in the middle of your vertebral bodies. Every so often you will be asked to perform a nephrogram or a coned kidney projection. This is an examination which is becoming less common, and the reason for that being that it is a projection which was often undertaken as part of an IVP or intravenous pyelogram, which I have talked/will talk about in the tutorials. However, every so often you might be asked to just undertake a nephrogram or coned kidney projection, and it's a fairly straightforward one. Rather than utilising a 35 by 43 image receptor, you'll be using a 24 by 30 landscape. This is a reasonably tightly collimated projection. The centering point, rather than being at the midpoint of the lower costals and iliac crest, is much higher. In this one, we're going to be centering the mid-sagittal plane halfway between the xiphoid, that is the bottom of the sternum, and the lower costal margins. This level, halfway between xiphisternum and the lower costal margins, should correlate to the level of the kidneys averaged out. We know that the right kidney is a lower structure than the left because the liver is quite a big organ, but that level between xiphisternum and lower costal margins will be about the average point. So you should be able to include the entirety of the kidneys bilaterally if you centre there. Otherwise, all of our other criteria and positioning tools are as per usual. Make sure it's a true AP position, make sure that you've centered in the mid-sagittal plane. It should be an expiratory phase, but to be quite honest, you're going to include it in either respiratory phase. I just get into the habit of, if I'm doing an abdomen, I'm going to do it in the expiratory phase. So simple as that. And this is what it should look like. On a nephrogram, you should be able to see the outline of the kidneys. Now, the kidneys can be a challenging thing to see. Generally speaking, for the average patient of the average body habitus, you should be able to see the kidneys because they will have a small layer of perinephritic fat. Basically, there's some fat, dense fat around the kidneys which aids in visualization. On this image in front of you, hopefully you can see the slightly denser structures of the kidneys. If the patient starts to increase in body habitus, what will often happen is that the liver and regions around the spleen and stomach will tend to get quite large, and so the upper part of the kidney tends to be harder to see than the lower part. Your average kidney, it's a 7 centimetre structure-ish. That's quite variable, and so you can normally estimate the location of the kidneys even if you can only see the lower pole of them. Now, on the critique, I've indicated here markers to indicate side and position and contrast timing. A nephrogram might be undertaken with contrast. That is traditionally the case with an IVP projection. So it's uncommon to utilise contrast anymore because it's uncommon to do these IVP ones. But if you're giving contrast, then put a marker on to indicate the time since contrast injection. All right, your kidneys will pick up iodine very, very quickly. Okay, so if the patient does have a dose of iodinated contrast, the kidneys will show up very quickly as a slightly more dense structure. So hopefully if you can see the renal outline, you can see it in its entirety. Otherwise, side markers are enough. And you can see that if we were to, we've got the lower part of the xiphisternum there, and we have got lower costal margins about there. And so that height there, which corresponds to about the L1, L2 level, cuts through the kidneys quite nicely. So now the oblique abdomen. Why and when do we do an oblique abdomen projection? There are a number of structures in the abdomen which are not exactly in a true AP lie. As such, it is worthwhile to understand how to do an oblique abdomen. I'm going to be giving you some numbers on the amount of obliquity, but that's an extremely variable amount. Structures which we might oblique the abdomen to visualise include the kidneys and the fallopian tubes, okay? Because the kidneys do not sit in a perfect AP plane. The fallopian tubes do not arise from the uterus in a perfect AP plane. And the last structure which we'll occasionally perform an oblique projection for is to have a look at the VUJ, or vesico-ureteric junction. For those people who have already done their tutorial, you should understand the significance of the VUJ. If you have not, then in the tutorial in an hour or two, we'll talk about that. So, while most of the oblique abdomen projections will be performed in a semi-supine position, that degree of obliquity, I want you to assume that 30 degrees is a standard abdominal oblique, but to understand that that might vary depending upon how your AP projection goes and shows anatomy. All right? Obviously, it makes sense that the closer the structure is to lying in a true anteroposterior coronal plane, the smaller the amount of obliquity that you need to apply. So, what should you do? The most challenging part of an oblique abdominal projection is to work out your centering point. Now, the level of it is going to be the same as it has been in the past, that is, halfway between the lower costal margin and the iliac crest. However, working out where to centre mediolaterally can often be the challenging part. Now, I have said here level of the iliac crest and lower costal margins, either one's good. Halfway between the mid-sagittal plane and the ASIS. Look, what I'm going to do is let's make things a little touch easier for ourselves. Instead, what I'd like you to do is this. Visualise that abdomen from the perspective of the X-ray tube. And from there, to try to imagine the soft tissue borders, or indeed see the soft tissue borders. We'll see if my drawing skills hold out a little touch. Wow, this is really easy to draw without the line showing up. That's great. All right. So, a bit of a rough drawing. It's actually kind of hard to use this tool, I must say. So let's imagine that the patient is in an RPO 30. Wow, that makes me look super drunk. An RPO 30 position, all right? So the patient's left side has been elevated on a sponge pad up to about a 30 degrees, such as that. Here's what I would like for you to do. Rather than trying to work out halfway between the mid-sagittal plane and the ASIS, simply visualise the soft tissue border on one side, visualise the soft tissue border on the other side, and then centre between those 2 points. Okay? So what that means is, regardless of the amount of obliquity, you want your collimation to be just touching the soft tissue borders on either side. And that's the easiest way to do it. All right. So, how should it look? In this particular radiograph, the patient has been given iodinated contrast. So that means that the collecting system of the kidneys and the ureter and the bladder are going to be far better visualised. This particular examination has been undertaken with greater than a 30-degree obliquity, and the reason why I know that is because the very tip of the nose of our Scotty dog on a 45-degree obliquity will just touch the edge of the vertebra. So that's about a 45-degree obliquity that the patient's been rolled into. Okay? So that's a rough guideline. If the Scotty dog's nose touches the edge of the vertebra, you've got a 45-degree angle. All right? I won't assess you on that. That's just a useful thing to know. So, on an oblique abdomen projection, yes, you should include down to the mid-pubic symphysis. Looks like we've trimmed off just a little touch there. And it should have, I've written here, similar rotation to an oblique lumbar spine. That really is quite a variable value depending upon, that is really quite a variable value depending upon what you are trying to show. Now, on this oblique, for example, we have projected the patient's left ureter quite a distance off the spine. Fantastic. We can visualize that one well. Many times the oblique projection will be performed bilaterally because we want to see bilateral ureters or bilateral fallopian tubes or bilateral VUJ. Okay? Now, so what we have done here is in this patient in a left posterior oblique, all right? In case you're wondering how I worked out that was a left posterior oblique, if this is the patient's right side, in a left posterior oblique, the iliac crest is going to be shown as a very, very broad structure, and the right iliac crest is going to be a very, very foreshortened structure, all right? But in a left posterior oblique such as this one, you can see, for example, that we have projected the ureter off the spine, and you can also see that we have managed to show the patient's right VUJ quite well. Okay? The take-home message is this, that a left posterior oblique doesn't necessarily always show left-sided structures well. Okay? It depends upon the lie of that structure relative to the coronal plane. Okay? So in this image, a left posterior oblique might show the left ureter well, but the right VUJ well. If this were a patient having a hysterosalpingogram, it might show the origin point, is it adnexa, I think, of the left fallopian tube quite well, for example. So, if the ureters can be seen, the external side should be projected off the spine, but the converse is true for the VUJ. I'm going to talk very quickly about the intravenous pyelogram examination. For those people who have already done the tutorial, this information will be just very quickly repeated. Here goes. We don't do them anymore. In previous years I would have called it a dying examination. I've made the call that 2019 is here, and so it's a dead examination. It's a dead examination because it requires contrast, and we want to try to minimise patients' use of contrast. It's a very technically challenging examination which requires a fair amount of radiographer skill, and that skill is currently not taught and not appreciated. It requires a radiologist or medical officer interaction, and they can be hard to find, and more particularly an IVP, an intravenous pyelogram, requires specialised equipment. It requires a tomography unit, which is a mechanical hardware modification to a standard X-ray room setup. That equipment is, to the best of my knowledge, no longer made, and the equipment which is still currently in practice either is going to be very, very difficult to repair and/or will be so old that the equipment will be too old to make Medicare billing a possibility, okay? Because Medicare billing requires that your X-ray machine is under a certain age. However, all of those things take a backseat to the fact that our CT scanners are now capable of sub-millimetre resolution. We're able to delineate a structure below 1 millimetre in size from being a separate structure to something adjacent. So we can definitively detect kidney stones well with CT. Yes, it's a higher dose, but it's a much faster, non-contrast, non-doctor requiring examination. All right? Instead, we will undertake a CT KUB to look for kidney stones, and ultrasound has a very, very strong part to play in this. So, CT KUB, why do we undertake it? For a patient who's got the possibility of having kidney stones, they have the characteristic loin to groin pain and hematuria, but we might also undertake one of these examinations to assess a patient pre or post transplant. If we wanted to assess, for example, whether or not a person who is about to offer one of their kidneys for transplantation, we might do a quick check to make sure that it doesn't have any stones in it and that it's of a good size, or to make sure that the other kidney doesn't have any disease in it and things like that. So this might be undertaken for a person providing a kidney for transplant or as part of the post-transplant scanning protocols for a recipient of a renal transplant. Non-contrast, coronal MPRs are going to be the most valuable ones there because we can then be able to visualise a kidney stone in the context of the ureter. I've also written here, curved coronal MPRs are quite valuable, and that means it's probably time to introduce somewhat of a new concept for you. And that is the curved MPRs. I don't think I've mentioned these so far in your studies. All right, here goes. We have got our loaf of bread. And on our loaf of bread, we can cut it up coronally, sagittally, or axially. Hopefully you're pretty much happy with that. In a CT scan of a human being or a loaf of bread, we can cut the volume of data up in the coronal plane, in the sagittal plane, or in the axial plane. Fantastic. Easy. Now let's go back to our bread analogy for a moment, and let's draw our loaf of bread looking at it from above. Now, if we had a very sharp, very fine knife, and we do, there's no reason why we couldn't cut our slice of bread in a series of curves, is there? So all of our slices cover a curved structure. No problem. When would that be useful? Well, let's say that you have a patient who's received a trauma, or maybe they've been part of an alleged assault, and they're unconscious, but with a possibly broken mandible. You can't stand them up for an OPG unless you've got about 9 or 10 rolls of tape to keep them in the OPG machine. So instead, why would you not, for example, CT their entire head and then do some curved coronals that followed the line of the mandible? If you were to do something like that, those curved coronals following the line of the mandible would create a digital OPG. Does that make sense? All right. So curved coronals can be useful for structures that are curved. You could do a curved coronal that follows the line of the aorta or the ureters or something like that, okay? And what it would end up doing is basically taking a curved structure and unfolding it into a flat plane. And it really is as simple as that. Okay? So, a lot of radiographers, when they'll perform a CT KUB, they might perform curved coronals with the curvature following the line of the ureter all the way down. Okay? Because once again, our loaf of bread, there's no reason why our curve can't be like that. We can do as many curves as we like. Okay? Now, so that's the idea behind a curved coronal or a curved MPR. Retrograde pyelogram. As I've just discussed in the tutorials, anything nephro refers to the kidney alone, pyelo refers to the kidney and the proximal collecting system, first part of the ureter. When we have got a cysto, it refers to the bladder. Now, a retrograde pyelogram, retrograde, hopefully we know what that means. Means that I can't use it for the tutorial 3, which was a KitKat question for tutorials 1 and 2. Retrograde means going in the wrong direction, okay? Anything which is retrograde is flow in the opposite direction to the way it normally occurs. The opposite of retrograde is antigrade. Antigrade means it's flowing in the correct direction. So, if we made contrast flow this way, it would be antigrade. If we made contrast flow this way, it would be retrograde. All right? Relative to the ureter. All right, so a retrograde pyelogram is an examination where we inject contrast into the patient's urinary bladder via a catheterization, and then, in all likelihood, we are then going to selectively catheterize the patient's ureters via their VUJ or vesico-ureteric junction. Why do we do these examinations? Well, we might have a patient who, for example, is going to be a transplant recipient or more likely a transplant donor. It might be a person who has got reflux, that is their vesico-ureteric junction doesn't work particularly well. We want to see if there's any flow of contrast from the bladder back up the ureter, in which case that would predispose the patient to things like chronic renal tract infections, or it might be from kidney stones. Now, what happens in these examinations? A retrograde pyelogram tends to start off with either in a fluoroscopy setting or in an operating theatre setting. It starts off with a urologist who is going to use a cystoscope, okay, so it's an endoscopic procedure which catheterizes through the patient's urethra and into their urinary bladder. From there, a catheter is introduced into the patient's VUJ, and then contrast is injected retrograde through the patient's ureter with the hope of filling up their kidney and collecting systems. Okay? It tends to be a bilateral examination, okay? And it can be useful, like in this case here, this patient's got these sort of weird filling defects in their bladder. Don't know what's causing that. It might be a bladder cancer or something like that, but that is a guess. Okay, so a retrograde pyelogram is a cystoscopically assisted contrast examination which assesses the bladder, ureter, and kidney. Micturating cystograms. Well, cysto means bladder. Micturating is the process of voiding via urination. A micturating cystogram is an examination where we are going to assess the patient's ability to have bladder integrity and urinary continence, okay? And also, once again, that vesico-ureteric reflux. So, commonly performed on kids. We're talking about from the 1 month to 2 years kind of a range. And once again, we're going to be filling up the urinary bladder. So we're going to catheterise this child or this patient, fill their bladder up with contrast, and then we're just going to wait for a little moment. We're going to see whether or not there is any naturally occurring reflux back up the ureters, suggesting that the UJ is not working well. Once we have given that a reasonable period of time to see whether or not there is any reflux, then we are just going to allow the patient to void that contrast, and then we can see the degree of bladder emptying, which can also be an important indicator for different pathologies. Okay, so often these are the kids who have had multiple UTIs. One of the things you've probably worked out by now is that in contrast imaging of the urinary system, that there's a lot of overlap in these examinations, okay? So a cystogram, they might decide to include a pyelogram, they might decide to include a nephrogram, they might decide to fluoroscope and video it while the patient is voiding and things like that. So there is quite a lot of overlap in our terminology. All right, that's genitourinary studies. Next part is hepatobiliary. Any questions about any of the genitourinary stuff before we continue on? All right. Hepatobiliary. I actually find this, it's a fairly interesting body system to me. Now, hepatobiliary system. So this is quite a good diagram, in fact, of what the hepatobiliary system looks like with all of the structures in situ. What can often be useful in your learning is if you explode this diagram a little touch. And what I mean by that is this. Do something like this. So we've got our stomach, and then we're going to do our first part of the duodenum, and then draw something like this. This is a diagram of the hepatobiliary system, but with none of the things in the correct spot, but it does allow for some good learning by virtue of the fact that it's got no superimposition of structures. So yes, the head of the pancreas doesn't sit anywhere near there, it sits right down here. But a diagram like this can be useful for learning pathologies. Hi there.
Hi, I need to pick up a laptop and I've heard
Is it?
That's it.
That's your one.
Thank you.
No problem. All right. So, diagram like this can come in handy for learning your anatomies and pathologies by just having none of the structures superimposed. So we might have the liver, the gallbladder, the pancreas, the duodenum, and the stomach, something like that. However, worthwhile to learn as separate entities, but the hepatobiliary system is something which I want you to understand is very, very tightly compacted together. That's important because an abnormality in one particular structure can often lead to an abnormality in the other. Here's an example. One of the worst ways to die is a carcinoma of the head of the pancreas. The reason for that is by the time that carcinoma has been found, it's well established. When I first started radiography, the average survival time of a person with a carcinoma of the head of the pancreas was 6 weeks, 42 days. Right? That's it. That's average. Now, with a lot more aggressive treatments and things like that, these patients have got 6 months. Fantastic, 180 days. better than it was. However, when you have got a cancer of the head of the pancreas, what it does is it expands out in all directions. Oh look, it's crushing the duodenum. Now you can't ingest nutrients, but if you like vomiting, then great. It's going to be fantastic for it because you can now have no nutrients passing. So that'll be good. And the next thing it's going to do is it's going to compress the common bile duct. So even if you did have food going past, you can't actually break down any of the fatty content, so any pooing that you are going to have is going to be a nasty fat filth steatorrheic nightmare of a time. So that's not going to be much fun. So what you've got is a person who slowly starves because they can't get any nutrients going past, and if they do, it's painful and debilitating for their life. So that's not much fun. I tell you that story basically so you understand that because these structures are so intimately in contact with the other, a cancer in one spot can destroy structures adjacent to it, not by the cancer, but just by compression, okay? Compression is one of the things which we need to understand in the hepatobiliary system, because anytime the tube is blocked, any of these tubes are blocked, there's going to be a consequence, okay? So tumours compressing one of the ducts can be a very, very bad thing, and of course we're also going to talk about some stones in our tutorials as well. Now, the image on the right hand side of screen is an ERCP image. In fact, if you were to do a Google Images search for ERCPs, you'll probably find this image fairly readily. Look for it online or steal it out of your notes. This projection in front of you here is exquisite. It is beautiful. If you could take this image and correlate all of those contrast-enhanced tubes and correlate those with what anatomy they are feeding into, you will have a fantastic knowledge base of hepatobiliary anatomy. Okay? So know what each of these tubes are. Know what that is and what it's feeding. Know what this is and what it's feeding. Know what this is and what it's feeding. Okay? Learn that stuff. All right. Gallstones and cholelithiasis. I'm going to be talking about the nature of gallstones in a fair amount of detail here because it is something which affects quite a few patients. So here goes. First of all, anything cysto in the body refers to a bladder. You have got two bladders, your urinary bladder and your gallbladder. When we refer to the urinary bladder, it just has the cysto prefix. In the gallbladder, it has the cholecysto prefix. Chole, bile, cyst, bladder. Okay? So bile, bladder is our prefix. Anything chole is going to refer to the bile process. Okay, is probably the best way of putting it. And so when we have cholelithiasis, we have basically got bile stones. All right, so we'll start off with that terminology. Cholelithiasis is the presence of bile stones in the gallbladder. We're going to be talking about pathology in a touch more detail soon, which is what happens when gallstones leave the gallbladder and travel out. We'll come to that in a little second. What do we need to know about gallstones and what do we need to know about bile? So, first of all, it's this. If I were to ask you whether or not bile is acidic or alkaline, there's a pretty decent chance that you'll feel confident in your answer that it's that it is an alkaline. After all, we've got stomach acid that needs to be neutralised, and an alkaline structure coming out of the common bile duct is going to do that. But that's not quite correct. Bile's got an extremely variable pH. It starts out most of the time as an alkaline structure, but if you store it for too long, it starts going acidic. Okay, so it is quite variable. Cholelithiasis is something which causes quite a bit of trouble in patients because when we have got gallstones themselves, they are relatively harmless. They can sit in the gallbladder and they just take up space. When I was a first-year student on placement at Cessnock Hospital, I x-rayed my grandmother. She came in for back pain, and because I didn't know how to center particularly well, I included her gallbladder on the x-ray, and I found, I think it was like 16 gallstones for her. And that's fine, because if gallstones remain in the gallbladder, they're harmless. They just sit there as a useless rock taking up space. Okay? It's when they travel out and block adjacent ducts, that's when things start to become a little bit of a problem. Okay? So, a patient develops gallstones. That gallstone gets ejected out of the gallbladder, and the most common reason for a stone being ejected out of the gallbladder is because of gallbladder contraction, and that is caused by eating a fatty meal. The purpose of bile is to break down fat. So, if you have a patient who can't excrete bile, that means that they won't be able to break down fat. That means the fat is going to pass through with their stool, and that's a condition known as steatorrhea. Please don't ask me to spell it. Look up fat in stool if you particularly want to know more details. Don't do it on your own internet browser, obviously, because I'm not responsible for the answer you get from then on in. Now, so a person shows up, they have got a stone that's been ejected out of their gallbladder, and now it's gone down into their common bile duct and caused blockage. The patient is going to have an ERCP, an endoscopic retrograde cholangiopancreatogram. Let's break that word down. Endoscopic, we're using a camera on a tube. Retrograde, we're going to be injecting contrast in the opposite direction to the way bile comes out. Cholangiopancreatogram, we're taking pictures of the pancreas and bile systems. Right. An ERCP, or endoscopic retrograde cholangiopancreatogram, is a fairly frequently performed examination. At John Hunter, for example, not uncommon for us to do 6 or 8 of these a day. Okay? What are they? It's a fluoroscopic examination, and it starts off with the patient in an an RPO position. It tends to be about a 15-degree RPO. In the diagram in front of you, you can see that this patient is lying prone with their right side raised. It's a fluoroscopic examination, and so the right posterior part is closest to the image receptor, making this an RPO projection. Hopefully that will make sense to you. Right? The reason why we put the patient into an oblique projection is twofold. Reason number one, a 15-degree RPO will project the majority of the hepatobiliary contents off the spine. The second, more practical reason, is the fact that this patient is going to be prone, and we need to find a way to get access to the patient's mouth to put the endoscope in. So a slight degree of obliquity is useful in this. So we oblique the patient to get scope access and also to project the hepatobiliary contents off the spine. What happens next? The patient is given a degree of sedation. They are not intubated, they are not ventilated, they are not unconscious. They are put in what is commonly referred to as a twilight sedation, where the patient is somewhat aware of their circumstances and somewhat able to undertake commands. When a patient is in an ERCP examination, there is a certain amount of art as much as there is science to knowing how much anaesthetic to give a patient, how much sedation to give a patient. And so these patients will have a variable level of consciousness. For some patients, they're particularly receptive to anaesthetic, and so a tiny, tiny dose will bomb the patient out completely. Other patients will require a fairly strong amount of anaesthetic to be able to be sedated. And there's one or two of you in this room who I know have got a fairly good resistance to anaesthetic. For those of you, this is anecdotal trivia and is not going to be assessed on your exam. And I don't know why this is the case. If you wanted to find the person who's most resistant to anaesthetic, redheads. Okay? Don't know why, but redheaded people are more resistant to anaesthetic. So look for someone else to roofie. Okay? So that I retract that comment. That's inappropriate. Okay. An ERCP examination is going to have a patient in a twilight level of sedation. They're going to need to understand some basic instructions, because in an ERCP examination, the endoscope is put into the patient's mouth. From there, advanced into the pharynx. The patient is encouraged to swallow that scope down. We're talking about a structure which is sort of about 8 to 10 millimetres across. The patient will swallow that scope down, and that's going to be pushed through the patient's stomach and into the first part of the duodenum. Once that endoscope is entered up into the point of the duodenum, then the hunt begins. The endoscopist / gastroenterologist / surgeon who's undertaking this examination is going to start looking for a particular structure. The structure that they're looking for is where the common bile duct empties into the duodenum. That structure has got two different names, and I'll tell you those ones now. The patient has got the actual raised structure where that common bile duct articulates with the duodenum is referred to as the ampulla of Vata. It is an approximately nipple-shaped prominence on the duodenum. Within that raised structure, there is a tiny little hole, a sphincter, and it is the sphincter of Oddi. O-double-D-I. All right? Now, what are we going to do? We've got this patient who's sedated. We've advanced the scope through pharynx, stomach, duodenum. We stop outside the duodenum and we search for this ampulla of Vata. Once we've found that structure, then what we're going to do is to catheterize it. All sounds very, very simple, but it's nightmarishly hard. I assume a few people here have seen an ERCP happening. So what we're talking about is an incredibly skilled user. We're talking about people who are controlling the movement of a metre and a half long endoscope with just little hand controls at one end, advancing it through the body. Excuse me for a second. It takes an incredibly skilled amount of use to be able to drive one of these things. Because once you've controlled this endoscope from a metre or so away, stopped outside the duodenum, you then have to thread a 1 or 2 millimetre catheter out the very end, or actually out the end of the side of the scope, and then feed it into this tiny little duct. It's really challenging. The worst part about it is endoscopes don't have a camera on the end of them. They have a camera on the side of the end of them. Okay? So it's the equivalent of trying to walk your way through a room, but you don't get to look forward, you only get to have a look at the wall alongside you. Okay? A really challenging sort of undertaking. If you get a chance to see an ERCP on upcoming placements, do get involved in them. You're at the point in your study where you'll be able to appreciate them, but also really do appreciate the technical skill involved on the part of the gastroenterologists. All right, so what's going to happen from there? Why are we going to do one of these examinations? The patient might have cholelithiasis, the presence of stones in the gallbladder. The patient, however, is more likely to have choledocholithiasis, and that is the presence of stones in the common bile duct. Stones in the gallbladder, cholelithiasis. Stones in the common bile duct, choledocholithiasis. So why do we do it? Commonly, the reason why is you've got stones, but it might be something interventional as well, and we'll cover the interventional and palliative components in just a second. But you might have a patient who is having trouble passing bile because they've got a cancer adjacent to it, and so that's one of the reasons why we might do an ERCP. So we start off, and look, rather than calling it an AP or PA of the right upper quadrant, we'll call it a gentle oblique of the right upper quadrant. And look, approximately 15 degrees of RPO is what we're looking at there. And in an ERCP position, you are going to be looking to include the entirety of the hepatobiliary system, and that's a really easy way of doing it. You're going to be using an image intensifier, and you're going to put the top of the screen at the top of the liver. You do that, you're going to include all of the territory there. Really as simple as that. Otherwise, you are going to screen and expose at the gastroenterologist's discretion. And this is what it should look like. When a patient has had a diagnostic ERCP, giving you some homework answers right here, the endoscope is going to come down the patient, cross over into their right side, and you can even see the outline here of the first part of the patient's bowel. Great. This catheter extends out of the endoscope, and at this point it's crossed through the sphincter body and is injecting contrast. The contrast is going to go up the patient's common bile duct, and then from there into their intrahepatic ducts. The contrast may also flow across the midline again to fill up the patient's pancreas. And finally, the contrast hopefully is going to flow into the patient's cystic duct / cholecystic duct, which is the duct which comes off the common bile duct and goes into the patient's gallbladder. All right. So, an ERCP is an endoscopic retrograde flow of contrast, which is going to fill up the cholangiosystem and the pancreatic system. I'll be talking more about some of the pathologies and rationale about stones in the tutorial next week. For the moment, however, what I want to cover is some of the components and technical aspects of an ERCP. Here goes. The patient starts off with cholelithiasis, the presence of stones within their gallbladder. The patient has a fatty meal, the gallbladder contracts, it ejects a stone out alongside some of the bile, and that stone gets ejected down and it becomes choledocholithiasis. It goes down and it blocks the common bile duct. That's a bad thing. You've got to get that stone out of there. How do we get a, 8mm stone through a 1 or 2 millimetre hole? It's going to be a difficult thing to do. stones can have different density. They might be a rock, or they might be muddy sludge. And indeed, when you do see an ERCP, when you see a stone actually being removed, don't be at all surprised that they do have quite a variable density to them. So, how do we get an 8mm rock out of a 2mm hole? The answer is make the hole bigger. And for that, we undertake a sphincterotomy. A sphincterotomy is the process of cutting the sphincter of Oddi larger. The sphincter will start out, magnified view, being an approximately round structure, and by the time we're finished with it, it's going to be a big teardrop-shaped hole. Here goes. When we're injecting contrast into the patient's common bile duct as part of the diagnostic part of the study, we're going to be using a catheter. And that catheter is literally a hollow little 2mm tube. Fantastic. Poke it in a hole, inject contrast through it, contrast fills up the structure. Great. Now, let's modify our catheter a little touch. We're going to take our catheter, and instead of it just being a hollow tube, we're going to attach a tiny little wire onto the outside of the tube in 2 points. That wire is going to be fed all the way back to the gastroenterologist. Now, if the gastroenterologist were to hold the catheter and pull on the wire, it's going to go from being a straight structure to being a curved structure, okay? You can see that this wire is fairly straight and the catheter is curved. The more we were to pull on the wire, well, that catheter might end up being quite a long curve indeed, okay? So, the more tension we place on the wire, the more the catheter bends. Right, so now we've got something which is approximately like a long bow shape. Straight string, curved bow. Why is that useful? Well, straight wire, curved bow. Place that straight string, that straight wire, against the edge of the hole, and then start putting some current through it. You start putting current through a wire, the wire is going to heat up. Now you've got a cutting tool, and by directing that heated up wire superiorly, you'll be able to cut that from being a round hole into being this big teardrop shaped structure, and the rock can come out. A sphincterotomy is the process of applying a heated wire on the outside of a catheter to a structure such as the sphincter of Oddi. That heated wire will allow you to be able to cut and cauterize the adjacent tissues to make the sphincter larger to allow the stone to come out. Two considerations exist with the sphincterotomy. Consideration number one, we don't want to cut too far. There are going to be vascular structures nearby, and so the gastroenterologist is going to try to cut the biggest tube hole they can without cutting through some blood vessels. Okay, but that's up to them. The second consideration is this. We are applying current to a human being. Human beings don't like a current being applied to them. So we need to make that patient part of the circuit to make sure that we don't just have empty current going into them. To that end, before we undertake a sphincterotomy, we have to make the patient part of the circuit. Here's how we do it. I want you to imagine a square of rubber, okay? Pretty big. That rubber is able to conduct electricity, and it's also adhesive. Attached to that rubber pad is a wire connecting it up to the ERCP endoscopy machine. If we stick that rubber pad on the patient, we have now completed the circuit. Okay? Current can flow into the patient and out of the patient. I tell you these things because the radiographer is very likely to be the person who puts this gel pad on the patient. Okay? So, you go in to do an ERCP, they go, oh yeah, this patient's likely to have some rocks in their common bile duct, we're going to do a sphincterotomy, and then you'll often be handed a big wobbly gel pad. Okay? Where do you put this wobbly gel pad? On as much buttock as you can. Okay? The gel pad wants to get the maximum contact with soft tissues, so you need a broad area of flesh, so you are going to stick that blue gel pad onto the patient's buttock or upper thigh, wherever you can get a nice big strong contact with the body, and that's going to have a lead coming off it to go back to the ERCP machine. We can now electrocute the patient as much as we like. Okay? A sphincterotomy involves cutting and cauterizing tissues, and so it's quite common for these patients, and I apologise for this mental picture, to either blow smoke out of their nose or indeed out of the anus. Okay? You will also get a somewhat enthusiastic smell because we are literally cooking flesh. So if you are of a somewhat gentle disposition and don't like the smell of cooking human, just be aware of that prior to your the other white meat. So yes, if you are so inclined, please be aware of that rubbing prior to going on place. Let's take a break for a couple of minutes. So the question was asked as to under what circumstances you might remove the gallbladder and whether it's beneficial to do so. So a little touch more background history, and this is useful and potentially accessible information. So I'll go through it with as much clarity as I can. Historically speaking, when they were looking for whether or not a person was predisposed to having gallstones, there was the 5F rule, and that is the person most likely to have gallstones, and I'm quoting the historical statement here, was female, fair, fat, 40, and fertile. Those were the patients who had the most likely predisposition for gallstones. Okay, so a light-skinned woman in her 40s was most likely to be the candidate for a person who's going to get gallstones. When treating a patient with gallstones, one of the things which the gastroenterologist and surgeon slash supervising team will do is to ask the question, is it more appropriate to take out the patient's gallstone as an acute presentation or to treat the more chronic presentation of removing the gallbladder? And that's probably the crux of your question. The answer lies in the likelihood of representation. If the patient is most likely to represent over and over, then most of the time the management is going to be, let's take that gallbladder out. If you had asked me 5 years ago what the management would be of a person whose gallbladder has been removed, I would have quoted things like patients being told to maintain a low-fat diet and things like that, which would mean that they don't need as much bile, which means that the contraction of the gallbladder, which isn't there, is less of a problem. However, in recent years, the management of patients with a gallbladder removal has changed, and these patients have basically been told, go about your normal life. Yes, it's nice to have a low-fat diet, but essentially go off and have a normal life. Now, in discussing the purpose of the gallbladder, I will just give you a quick revision of physiology for something which you probably already know, but it does bear repeating, and it's this. The purpose of the liver and pancreas is a filtration and enzymatic creation process to create bile. The purpose of the gallbladder is to store and concentrate it. We don't require bile every moment of our lives because we're not having a fatty meal every moment of our lives. So we create bile. The body says, do we need it at the moment? If the answer is no, then the bile travels into the patient's gallbladder where it's stored and concentrated. Okay? So, if a patient has got no gallbladder because they've got a recurrence of stones, it needs to be removed for long-term management of the patient, you would think that the good advice would be maintain a low-fat diet, but for whatever reason, that seems to be not so much the current advice. So, when do we take it out? Answer number 1, if it's likely to be a recurrence. Answer number 2, surgeons like to cut. So, if they can make some money out of pulling something out of you, they will. That's the somewhat cynical answer as well. Does that answer your question in terms of the management? All right. Great. All right, so let's launch on now about some of the actual images that you might encounter for a patient during an ERCP. So this is an ERCP image, and this is from the perspective... Oh, sorry, thank you. Good point. Thank you, thank you, thank you. All right. Whew. You just thought we were going to watch a movie then? Okay. In a sphincterotomy examination, this is from the perspective of the endoscope, so we're looking out the side of the scope. This is the catheter, which is coming out of the end of the endoscope. This is the metal wire that you can see, and so what they're going to do is the gastroenterologist is going to advance that catheter until the middle of that bowstring, the middle of that wire is sitting over the middle of the sphincter. Apply tension to create the strongest bowing that they possibly can, so really, really curve that catheter to make that string nice and tight. Apply a current, slice upwards. You're going to end up with something that looks like that. You can see the tissues all the way around here. They're white because they've been cut and cauterized, and you could probably park a truck in there, okay? So an 8mm stone is not going to be so much of a concern. It's going to relatively easily come out of that. Do those anatomical pictures make sense to people? These are the sorts of things you will be seeing live on an ERCP when it is performed. No. They basically, by virtue of the fact that it's a heated wire, it's going to cauterize, so seal off those tissues as they occur. So basically, so long as they don't hit artery or vein, that's what they get for the rest of their life.
So it doesn't matter the size of it, so they can cut like 12 or that.
Doesn't really matter too much. The limiting factor is that there's, so I don't know if you can see following the line across here, that little bulge of tissue. What I don't know is whether or not that's a ligamentous structure or whether it's an artery. I don't know my anatomy well enough for that. So they will cut as far as they can. They can only really cut in the direction that the wire is sitting relative to the catheter. So they've only really got one cutting plane. So that is a sphincterotomy, cutting the hole bigger to let a stone in. Zach? So this is my, I'm now theory crafting, okay? So bile would be released when you have a fatty meal. If the bile is not needed, it goes up to the gallbladder. If that hole is larger and doesn't work functionally as a sphincter, you would expect a continuous minor leakage of bile out into the common bile duct fairly regularly because there is no sphincter process. So it might be the case that the gallbladder doesn't have enough stored and concentrated bile from that point on, but what I don't know is if there's a feedback mechanism which would increase production to compensate for it. That's my best answer at the guess. So that's all theoretical stuff. I don't know as much about that particular mechanism as much more than that. All right. So we've got some rocks in there. We need to get rid of them. Method number 1, cut the hole bigger. That's great. We can now allow the stuff to come out. The next thing that we're going to need to do, however, is to try to convince those rocks to come out. The following statement is very likely to be the basis of an examination question. Here goes. Understanding that these stones can have a rock-like structure all the way through a sludgy mud-like structure, there are a couple of techniques that are utilised to get those stones out. And the rough rule of thumb goes like this. If it's a rock, we can use a basket. This will all make sense in a moment. And for anything, we can use a balloon. Okay? Rocks need baskets. Anything needs a balloon. That will all make sense a little touch more in a second. Here goes. When we have got a rock or some sludgy rocks in the patient's common bile duct, we need to be able to remove those. We might have done a sphincterotomy to increase the size of the hole, but we still need to find a way to convince that material to come out. So what we're going to do then is we're going to use another specialist type of catheter. We're going to have our standard catheter which is going to be that sort of same hollow tube. But instead, what we're going to do is we are going to have, over the top, an uninflated balloon, which is going to have a little lead attached to allow us to blow it up. We're going to insert this catheter into the common bile duct, squirt a bit of contrast to see if there are any filling defects which might indicate a stone. And once we have found the location of that stone, we then push the catheter, and more particularly push the balloon, past the filling defect. Okay? So, we've got some little rocks right here. We advance our uninflated balloon past it, higher up in the duct, and then we are going to inflate the balloon. That inflated balloon is going to be blown up to the point where that it was going to fill the entirety of the common bile duct. Once we've got that done, pull the balloon out. Okay? Advance the balloon past the blockage, inflate the balloon, pull the balloon out. Deflate it, do that as many times as you need to. Doesn't matter if you've got a big old dense rock or you've got mud, if you push that balloon past it, fill it up to the size of the duct and pull it out, it's going to pull all that junk out with it. Okay? So, method number one for removing a stone out of the common bile duct is by using a balloon catheter to you blow the balloon up past the blockage and yoink it out. That's method number one. It's useful for gravel and mud. It's useful for big, nasty individual rocks. Phase two. You've got a big old rock there, and that thing is well and truly stuck. It's impacted in the walls, in some axes, and it's just not going to come out. We really need to give that thing a good yoink to get it out. So what do? Our next specialist catheter is going to be one with a cage or a basket attached. Here goes. Imagine getting 4 pieces of wire. And they've been welded together at both ends. If you push those 2 ends together, the cage is going to expand out. If you put that cage under tension, it's going to tighten up. So what do? A basket or cage style of stone retrieval involves sending an unexpanded cage adjacent to the stone and then opening it up. Once that cage is opened up, with a bit of a wiggle and a shake, hopefully you can convince the stone to go between one of those bars of the cage, and then once you've achieved that, tighten it up around the stone and it should be snared inside the bars of the cage. Once that's done, pull the cage out. Okay? So a cage is going to be useless for mud and gravel. Okay? Those tiny bits of debris are just going to fall between the bars of the cage. But if you've got a big solid rock that's impacted in the walls and is not coming out, send the cage in, expand it, snare it, tighten it, yank it out. Okay? So, how do we remove stones from the common bile duct? If you've got a rock, then you use a cage or a basket to take it out. If you have got any type of stone, however, a balloon can potentially pull it out. And while a sphincterotomy is not a method of removing the stone, it will facilitate easier removal by having a larger hole. Does that all make sense? All right? Cut the hole to make it big, to make things easier. Use a balloon for anything and use a basket or cage for the big rocks. All right, now we're on the home stretch. We've got a patient who very sadly has got a cancer, chronic inflammation, something like that. The common bile duct is fine, but it's being compressed by an adjacent structure like a cancer. That's bad. We want the patient to be able to get bile out to break down fat. So now we need to find a way to stop that compression of the duct. All right. So now I'm going to talk about stents. I'm going to talk about plastic and metal stents. A stent is a structure which is put in the body to keep a tube open, is probably the best way of phrasing it. Now, keeping a tube open requires you to do two things. Stop that compressive thing being able to come in any further, and wherever possible, push the walls out. Okay? Stents can be made of plastic and metal, and I'm going to give you a very rough guideline here. Plastic stops anything coming, plastic stops it being crushed further, and metal opens things further out. That's a rough guideline. So you use a plastic stent if you want to make sure that we can keep drainage, but if you need to keep that duct even further open, then you might use a metal stent. Now, the word stent, we're using it in the context here of the bile duct, but a stent can be used in vasculature as well, okay? So you might have had a family member or a friend who had a heart attack and they did a stenting of that blood vessel. What we're talking about there is inserting a metal tube into that vascular structure just to keep it open. All right, but let's talk about the common bile duct to start off with. So we've got a patient. Tragically, they've got a carcinoma of the head of the pancreas. That pancreatic cancer is crushing their common bile duct, and they're starting to get all the symptoms of that decreased function. They're starting to get jaundiced. They're starting to have fat passing through in their stools. They're getting nausea and vomiting. They get diagnosed with this cancer. Tragic. Unfortunate. But what we want to try to do is to maintain the quality of this patient's life for as long as we can, and that includes draining the bile out. So, we do an ERCP, and we decide to put in a plastic stent. That plastic stent has got an objective of being one end of it hanging out into the duodenum, and the other end, notice that we've got our cancer mass right here, the other end of it should be above the cancer. That is, you've got an end either side of the blockage, right? Simple as that. Now, these plastic stents start out in life, once again, as a tube. But these ones are short, you can see them there, and they're basically, we'll put a catheter into the patient's bile duct and then push the tube over the top. These plastic tubes have got little flanges on them, little spurs of plastic that stick out like that, so that when we push them into a position, those flanges dig into the wall and stop it falling out. All right, simple as that. So, patient comes in, they've got a cancer, we need to put in a stent. We'll do a diagnostic ERCP. We'll see how big their common bile duct is. We'll find a stricture. A stricture is a narrowing of a tube. And then we'll put a plastic stent to make sure that we have flow of bile coming out. And you'll know at the moment that this patient has a successful stent insertion because they are going to have a back pressure of yellow bile coming straight out of that plastic stent. All right. Last concept of the day, the metal stent. Here goes. Stents 101. Step 1, imagine you have got some wire in a grid. Simple. Step 2, fold that wire so it's in the form of a tube. We've now got a tube of chicken wire. Fantastic. If you grab the end of that tube and pull, it's going to get longer and narrower. If you get the end of those tubes and push together, it's going to get shorter and broader. Everyone happy so far? All right? We could construct that tube to have whatever length and whatever diameter we want. Great, so we do that. Then what we do, get your catheter once again, then get that stent super duper tightly over the top of the catheter with a little plastic cover on it. Push the stent where it should be, pull the cover off, and it goes poing and goes back to its natural diameter and length. Happy enough? So that's the purpose of a stent. It starts out life as a very, very long, narrow metal tube of chicken wire, and then when it's deployed and the cover is taken off, it shortens and expands out. The advantage of a metal stent like this rather than a plastic stent is that a metal stent will exert force externally, okay? The plastic stent stops crushing inward, but the metal stent will continue to push outward. It's going to try to get that, whatever tube it's deployed into, up to its maximum normal diameter, okay? So, if we have got a patient who has got a cancer of head of the pancreas, for example, we might ask ourselves, how far advanced is this cancer? Is it really, really advanced and we just need a plastic stent in for the next few weeks while the patient has got a good quality of life in their final days? Or have we got a patient who's viable for having some longer term treatment, in which case we might want to put a metal stent in there to really push that tumour mass away and to increase that flow of bile outwards. And there's no reason why you can't use a plastic stent inside a metal stent, for example. You can use them in concert with each other. Okay? Now, in your studies, when we talk about vasculature next week, and also over the next few years when you start your angiography studies, we're going to be talking about stents quite a bit. And most of the time in vascular studies, a metal stent is what we're talking about. But at the end of the day, it's a roll of chicken wire, okay, with the pure intention of pushing a tube outwards. So, collating all our knowledge together. Hepatobiliary system's job is to store bile and concentrate, or the gallbladder stores and concentrates it, and the bile is created by enzymes from liver and to a certain extent the pancreas. If we have a fatty meal, gallbladder contracts, ejecting out bile to break down fat. Patients who have got a one-off stone will often have an ERCP to have that stone removed, but in the longer term they might have their gallbladder completely removed. Okay, and the gallbladder removal process is something I just want to touch upon here for a little second. But an individual gallstone, we might take it out with a basket or a balloon. We might assist that process by cutting that sphincter open, and if we have a long-term need to push those walls of the vessel out, we might use a stent. All right, now I want to introduce a few concepts here, but I'm going to expand upon this procedure next week when we have our lecture on operating theatre stuff. So this is a bit of an older photograph here, but we can clearly see a couple of things. First of all, we can see duodenum, and this is our common bile duct coming up. Hopefully you can see just a tiny, tiny nub there of a patient's cholecystic duct as well. Now, broad concepts to start off with. A patient presents and they have got a predisposition towards stones. They might have had an ERCP or two, but we've decided, actually, you know what, it's time to just take that gallbladder out. Most of the time, When we take a gallbladder out, it is through what is commonly referred to as keyhole surgery, okay? But the most correct term for when we take out a gallbladder without a big incision, it is a laparoscopic cholecystectomy, okay, or a lap chole. Laparoscopic, it is a scope-assisted procedure. Cholecyst, bile bag, ectomy, removal, okay? So it's a scope-assisted bile bag removal. The surgery is called a lap chole, a laparoscopic cholecystectomy. The procedure which a radiographer will do as part of that examination is an operative cholangiogram. I'll say the next bit slowly just so it's clear. The surgery is commonly referred to as a lap chole. The imaging procedure which the radiographer does is commonly referred to as an op chole, short for an operative cholangiogram. So on placement, you might well hear a phrasing similar to, we do an op chole as part of a lap chole. We do an operative cholangiogram as radiographers as part of the larger surgery of a laparoscopic cholecystectomy. We do an op chole as part of a lap chole. What's involved? I'll go to the greater detail next week when we start to talk about our operating theatre procedures, but the short version is this. We are going to perform an antegrade cholangiogram. Contrast is going to be inserted right there through the base of the gallbladder's cholecystic duct. And the flow will go both antegrade and retrograde. Okay? So the contrast is going to flow retrograde into the liver, and that's great, but we're more interested about the flow going downhill, antegrade, inferiorly, into the remnant of the common bile duct and cholecystic duct. I'll talk about why we do that operation next week and the logistics of undertaking that operation. For the moment, however, recognise it's a surgical precaution as part of removing a gallbladder is probably my best way of phrasing it. Now, a couple of quick things I want you to just be aware of. We can do cholangiograms using fluoroscopy, but there are currently examinations which are starting to grow in popularity, the CT cholangiogram. Okay. Step one, give the patient an iodinated contrast that's likely to be picked up by the hepatobiliary system. Great. What it's going to do is to fill up the intrahepatic ducts and the common bile duct and hopefully even the gallbladder itself. Then we do a CT. Now, I would love for somebody to tell me what it's not a coronal, what MPR we have used to show this image. Curved one. Fantastic, whoever said that. It's a curved MPR. Because we know that the bile duct is going to curve over quite a few directions over the course of its travel from superior to inferior, by doing a curved cut which follows the line of the gallbladder, the line of the common bile duct, we can see the entirety of that common bile duct as one linear entity, and that's what we've done here. So this is a curved MPR to show, get rid of that for a sec. This is a curved MPR to show the entirety of the common bile duct, and you can see about 467 stones in there. So this patient's got a combination of some gravel and probably some mud in there. Really, really nice examination. We get a good lot of pictures, but we need a good CT scanner and a good operator to be able to construct those curved MPRs, okay? So they are growing in popularity as scanners get newer and our techniques improve. We can also do a CT cholangiogram, and I want to just, I won't be asking you an exam question about this, I just want you to be aware of its existence. If we had a patient who, for whatever reason, we could not drain their common bile duct, the tumour mass of that pancreatic head is just too big, or it's a cancer of their duodenum as well, or for whatever reason we can't get any drainage out, we wanted to get rid of a patient's bile, then one of the ways we could do it is percutaneously, literally put a tube right in through their liver and into that bile duct, and patient could potentially be drained through there. If we do have a drainage point, we could also inject contrast into it to make sure everything is where it should be. That's the rough version. And last one, an MRCP, a magnetic resonance cholangiopancreatogram. Very, very pretty, not done very often at the moment, but if you have got a patient who is magnet friendly, and that can be quite a nice way of imaging them. But at the moment, fluoroscopic studies are by far the most common way of imaging the hepatobiliary system, both intraoperatively and fluoroscopically. Any questions about any part of that material for today?
What are the chances, or is the history of stents actually getting crushed in from the pressure of what tumours?
A plastic stent is quite thick walled, and it is remarkably hard. It's easy to compress it a bit, it's much harder to compress it a lot. And so plastic stents are really good at least allowing some flow through. A metal stent, well, what I'd encourage you to do is when you're out on placement, or indeed I think we're going to put some in the labs of out-of-date stents. One of my colleagues at John Hunter delivered some the other day. If you get a chance to give a stent a push, it doesn't really require a lot of force to collapse it. Once the compression caused by an external force such as a tumour exceeds that amount, it will start to compress in. However, the question becomes how long it takes versus the patient's expected life. So yes, it'll eventually compress, but it will probably outlast the patient's life. Thank you, folks. I'll see you in the tutorial or next week for our final lecture on operating theatres.